So, well, thank you all for attending this this webinar on women with ALD. My name is Marc Engelen. I'll try to summarize what we know about the symptoms in women with ALD. I'm required to read this full message, so I will do that now. The information and services provided by ALD Connect are for informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnosis, or treatment. If you or a family member are ill or suspect that you or a family member are ill, seek professional medical attention immediately. ALD Connect does not recommend or endorse any specific physicians, treatments, procedures, or products, even though they may be mentioned on this site. Please note that your participation in this webinar is completely voluntary and that this webinar will be recorded and may be available for rebroadcast at a later time. All right, then now we can start the actual webinar. What we're going to do to better understand the signs and symptoms, it's probably a good idea to do a small introduction on neurology, just a few slides to define some concepts. Then I think before we talk about women specifically, it's probably a good idea to give a broad overview of the disease, the biochemistry, but also the most prominent signs and symptoms. And after that we can go into the specific manifestations of ALD in women and maybe talk briefly about some future studies. And after that there's going to be time for questions if there are any, and well, I do my best to answer them if I can. Well, to start with, ALD is basically, for a very large part, a spinal cord disease. That is the organ that is mostly affected and that is responsible for many of the symptoms that men with ALD and also women experience. So I think it's good to discuss some basic concepts about the spinal cord. And the spinal cord is basically a very thick cable that connects the brain to the rest of the body, for instance, to the nerves. And the spinal cord is divided into specific little cables called tracts. And the most important tracts, especially in relation to ALD, are the corticospinal tract in red, which is a descending tract, important for motor function, and the dorsal columns and the spinothalamic tracts, which are ascending tracts. They are sensory. And, excuse me, so like I mentioned, the corticospinal tract is very important in motor function. It is important to control the muscles, and if damaged, muscles become, you lose control over your muscles. Muscles become, you get a phenomenon called spasticity. The muscles become very stiff, and during neurological examination the reflexes become very brisk. For instance, you can get a clonus, repeating the little jerks in the ankle, for instance. And the other tracts, the dorsal columns, is very important for position sense. Your body can, of your brain, gets information about the position of the joint, and you can imagine then when it's damaged that walking can become difficult because the brain lacks information on what position the foot or the leg is in, so that makes your gait unstable. And the spinothalamic tract is important for carrying information like pain and touch. So these tracts, the previous slides showed a cross section, but this illustrates how these are longitudinal tracts, so connecting the brain to the other tissues. So if the spinal cord is damaged, neurologists refer to that as a myelopathy, which means nothing else than disease of the spinal cord. And this short slide illustrates the most important signs and symptoms that occur if the spinal cord is damaged. So you get, below the level of damage, you get an impairment of all sensory functions. You lose control over bladder and bowel, and the limbs become, well, if it's partial, if there is still some function in the limbs, you lose part of the control. But if the spinal cord is completely transected, you lose full control over your limbs. And at what level symptoms occur depends on the level of injury. For instance, if the level of injury is in the neck, the arms are affected, and if the level of injury is lower, only the legs are affected. In ALD, you also often hear the term neuropathy, and that refers to the peripheral nerve, because the spinal cord, the tracts in the spinal cord are carried to the skin and the joints through peripheral nerves. And when nerves become damaged, you get different kind of symptoms. The most typical symptoms you get when the nerves are damaged are pain or tingling or numbness. And a neurologist would, at a neurological examination, you would find low or absent reflexes, or absent pinprick sensation, absent vibration sense, etc. And the distribution of these symptoms is usually in what we call a stock and glove distribution. So the longest fibers are the most affected. So those symptoms occur predominantly in the feet or in the hands, the most distal parts. At least in the beginning, and then they can gradually progress and become more proximal. And this is what is referred to as a peripheral neuropathy and a polyneuropathy. So this was the brief introduction in neurology, and now we can apply this new knowledge to ALD more specifically. Well, this is probably nothing new for all of you. You know that ALD is a metabolic disorder. And metabolic disorders, well, you can classify them in many different ways, but one way to classify them is by which cellular compartment is mostly affected. And the defect in ALD is in the cellular compartment that's called the peroxisome. So you could classify it as a peroxisomal disorder. And it is caused by mutations in one specific gene called the ABCD1 gene, and the biochemical consequence of mutations in this gene is that you get difficulty in degrading a certain compound of a certain acid. Very long chain fatty acids, these accumulate, and we believe that the accumulation of these very long chain fatty acids is through mechanisms we do not fully understand, responsible for the damage to the end organs, and therefore to the responsible for the symptoms and signs that you experience. Well, to establish the diagnosis, most commonly we use biochemical tests, because this very long chain fatty acid, and the most important one is C26, and you can see a chemical representation at the bottom of this slide, can be measured, for instance in plasma, and this is a diagnostic test that is commonly used, because in patients with ALD, C26 is grossly elevated, as you can see in the rightmost graph. But as you can see, in males, C26 is always abnormal if you have ALD, the little blue dots. But there are a few women with ALD, roughly 15%, that can have plasma C26 values in the normal range. So this test, if you use only this test in women, you will miss a certain percentage. So in women, it's recommended to do genetic analysis. To establish a diagnosis, you do mutation analysis of the ABCD1 gene. Also briefly, it is an X-linked disease, and because women have 2 X chromosomes and men only 1, I mean this is what determines gender, the inheritance pattern is a little bit different. So we have 2 scenarios. Say if in a family the father is affected, he can never pass on ALD to one of his sons, because the sons get an X chromosome from their mother and a Y chromosome from their father. But all his daughters will have ALD. That is the right diagram. Other scenario, if the mother has ALD, she can pass on the gene to her daughters and sons, because they get an X chromosome from the mother, and and one from the father, but the one from the father is in this scenario does not carry the ALD gene. So in this scenario, there will be a 50% chance of an affected male or female child. Okay, now back to from biochemistry and genetics, we can go to symptoms. In this graph, this is a representation to kind of summarize how we view the natural history of ALD at this point. In contrast to many other metabolic diseases, if you are born, whether you're male or female, you're always asymptomatic. And only during childhood or sometimes much later do symptoms develop. And in boys and men, usually the first symptom is adrenal insufficiency, somewhere in childhood. That is the usual scenario. And then for men, when they become adults, they gradually get the myelopathy that we discussed before, with the gait disorder, with urinary symptoms, with sensory symptoms, etc. And of course there's large variation between different individuals. Some have symptoms when they're 25, some at 50, but that is generally the course of the disease. And then in men, they can also develop inflammatory lesions in the white matter of their brain, and we think that can occur probably at any age. Traditionally, it was always assumed that it was very typical in childhood and very rare in adulthood. But now that we follow patients for a long time, we get the idea that it is not that rare in adulthood. Now finally, after this rather long introduction, we can focus on women with ALD. And I would like to say that the data I'm going to present is from a study we did a few years ago, and I would like to briefly talk to you about how this study was how this study was designed. Because what we wanted to avoid was to only look at the women that we knew in our clinic, because then there would be a risk that we would only look at women with complaints, and that we would be very biased, because it is, of course, if you see people in a hospital setting, it is more likely that they have signs and symptoms than if it is more likely for those people with symptoms to seek help. So what we try to do is, because we are a small country, so we know most of the patients, we tried to also get relatives of the patients we knew to get a large unbiased sample. And all these people we examined. We did clinical examination, we also did some tests, and we are planning in the future, we're currently doing that, to examine them again more than 5 years after the initial examination, to see if we can get some information on progression. I have to apologize. I see that I used my old slides, so I'm going to switch now. 1 second.
And this switch, Mark, will be cropped out, so in the final recording it won't even be there.
Thank you. I apologize. I got better slides now, I think. All right. Thank you. So we can now go on to the findings from our study to define the signs and symptoms in women with ALD. And you can see a link. I'm going to point it out with my cursor. And this is the link to the paper. So if you want to have more detailed information, if you want to look at the data for yourself, you can download the PDF at this site. And I think because it's more than 1 year after publication, that it's open access. If not, then me or one of the other authors will be happy to provide you with a copy. So in the end, we were able to look at 46 different women from a large number of families, And this graph represents the age at examination. So you can see we had a few rather young women and a few a few elderly women, and most were somewhere between 40 and 60. And I'm going to start with this slide here, and I'm going to put little red dots next to the line we're going to discuss. So first we defined which women are symptomatic, and with symptomatic was defined as signs and symptoms that we could actually attribute to ALD. So that would be neuropathy or myelopathy. And as you can see, for the total group, it was quite a few. 31 out of 46 women had signs or symptoms that you could attribute to ALD. And if you look at the three columns, then you can see that younger women under 40 it was not very probable that they would have symptoms. But the older they got, so above 40 and especially above 60, you can see that almost all of them had symptoms. And these symptoms were most typical myelopathy, and from the myelopathy the most typical symptoms were gait disorder and incontinence, both for urine and for feces. So I'm going to try to switch back now. Excuse me, sorry. So to summarize that, one of my colleagues made a beautiful graph. You can see the bars here for the three groups, the young women, the middle-aged women, and the elderly women, and you can see the older the patients, the higher the probability of being symptomatic. So age is the most important determinant of symptomatic status in a woman with ALD. And also what was surprising to us is that so many women complained of fecal incontinence. Actually, I've seen many men with ALD and I can't remember any of them complaining about that, or at least it's relatively rare. So this seems to be especially prominent among women. And the most important differences with men with ALD are that on average symptoms occur at a later age. Of course, as always in biology, there are exceptions. We know a few women who were actually symptomatic in their early 20s, but generally that's relatively rare. It is relatively rare to have symptoms before you are 40. And in men, most people will develop symptoms in their 20s or at least in their 30s usually. Well, adrenal insufficiency is very rare in women. Or is it? There's a little remark I want to make at the end of this presentation. But cerebral ALD that is really extremely rare in women. That is something that you hardly ever encounter. And the fecal incontinence is prominent. Okay. So you might wonder, why are women with ALD different from the men with ALD? And why are there such enormous differences between different women? Why are some relatively severely affected while others have few, if any, complaints? Well, we thought that the most likely explanation would be the phenomenon of X-inactivation. As we saw in the genetics part, women, in contrast to men, have 2 X chromosomes instead of 1. So they have 2 copies of the ABCD1 gene, and they will have 1 mutated, defective copy and 1 normal copy. So then you could think, why would they have symptoms at all then? Because they have a backup copy. Well, that is because in every cell, one of the X chromosomes is inactivated. It is a process called X-inactivation, and we think that that process is random. So during the early fetal development, each cell deactivates at random one of the copies. So all women are a mosaic. They consist of cells that have normal ABCD1 function and cells that have abnormal ABCD1 function. as beautifully shown in this calico cat, I think the correct pronunciation is. So women are a mosaic too. So we thought that would be a very likely explanation. And well, I'm going to briefly, for people who want details, you can download the paper and look at the details. We try to look at X-inactivation in the women in our study and see if it was correlated in any way with symptoms. If women who had many ALD cells were worse off than those who had few. We could not find a pattern. But I have to say that that could also be a technical issue because, well, one, of course, we could not look in brain or spinal cord. We had to look in skin fibroblasts, and we assume that that is a good representation of X-inactivation, but it might be that there are differences between skin and central nervous tissue. So that is a limitation. And of course, we were very happy that we could find 46 women who were able to participate in the study. But still, to do statistics, it's a relatively small number. So it is possible that if we had a larger number of women to examine, that we could have found an association. But that is something that maybe we can revisit in the future. Okay, so now we know what kind of signs and symptoms women develop, and what do we recommend for follow-up in women? Well, first of all, it's kind of a obvious statement, but we think that one of the important things of this study was that it has now been clearly established that women with ALD are not merely carriers, but they have ALD, and that helps. And now that it is clearly written down, to correctly diagnose women, because some time ago, maybe 10, 15 years ago, it could happen that that's when women visited the hospital with signs of spinal cord disease, that they would, for instance, get the diagnosis of primary progressive MS, because people would not consider ALD as a cause, especially if there was no family history of ALD. And of course it is important to have the correct diagnosis, obviously, because as a genetic disease it has well, obvious consequences, and genetic counseling is generally would be very important. And also it avoids incorrect treatment. For instance, for MS, medication is often started, which of course in the case of ALD is generally not effective. But anyway, women do have ALD, but it's a different ALD. So because we discussed that cerebral ALD is extremely rare, we don't do the yearly MRIs that we do in the men. And at this point, we don't do adrenal function tests. But there are important symptomatic treatments available. So what are the signs and symptoms that many women with ALD have to cope with? Pain. Pain is rather common. Pain in the low back, pain in the legs. Spasticity, obviously, giving problems with mobility. And bladder and bowel dysfunction. Well, for pain, if you consider neuropathic pain, there are certain medication available that you can discuss with your neurologist that can be effective. And if not effective, you can also refer to a pain clinic where there are other treatments available. For the spasticity, well, for mild spasticity, usually you start out with physical therapy. But also for spasticity, there are different medications that you can try. And for more advanced spasticity, it is more and more common to start with, for instance, botulinum toxin injections. Well, spasticity treatment is rather complicated and is generally something that is coordinated in a rehabilitation center. And that is something that is a referral that is very important, because it can greatly reduce the amount of handicap in daily life. For the bowel and bladder dysfunction, there is some medication that, especially early in the disease, when there's the urge complaints, the urge incontinence, there's medication that can reduce those problems. Unfortunately, when the disease advances, that medication becomes less and less effective, and eventually, yeah, most people do need incontinence materials. But there are some newer materials available that can also greatly reduce handicap of these very unpleasant symptoms in daily life. And then there's the thing, well, everybody always said that adrenal dysfunction is very rare in women with ALD, and in our study we didn't specifically look at it. And about 2-3 weeks ago I was at a meeting of ALD Life in London in the United Kingdom, and I was approached by a woman who was recently diagnosed with full-blown adrenal dysfunction, who was now on medication, and well, we had a lively discussion there. It might actually be a good idea to, in the future, maybe look at our population to see if it might not be a little bit more common than we think, especially because the symptoms of adrenal dysfunctions can be quite vague and aspecific. So that is definitely something to look at in the future. And there is a questionnaire at the end of the presentation, and it would be wonderful if all of you could fill out whether you ever had an adrenal function test, and if so, what the results are, because that could maybe point us in the right direction. So, future studies. What we are doing at this time is all the women who participated in our original studies, which is already about 6 or 7 years ago. The second part of this year, we're going to ask all of them to come in again. We're going to examine them again, and of course we're going to compare their current situation with that a few years ago, and that will give us an idea on how progressive the disease is in women, whether it's similar to men or maybe less so, we don't know. And when they come back, we're also going to consider, we're going to do questionnaires, and if there's any sign of an adrenal problem, we're going to offer them an adrenal function test. So, to summarize, the most important message is that women with ALD are not carriers, but women with ALD have ALD. That symptoms are relatively rare before the age of 40, and that there are differences with the men. So in our institute we have many people who are working on ALD, trying to develop new treatments, and yeah, many of the faces you see on this slide have also helped to provide nice slides for this presentation. So I think that now we can skip to the question part, and I'm going to, the first question I received from Inna by email, which is rather long, so I'm going to read it and then I'm going to try to answer it, and then through the chat I think I will receive the other questions. So the first question is, it's actually 3 questions in one basically. I am a 41-year-old woman with AMN. Understanding the pathology of this condition, it makes sense that it would be progressive, as we are told, but I know myself and some others I have been in contact with do seem to have exacerbations, and other times some improvement in functional symptoms. Some days, weeks, months can be better or worse than others, and I have found no obvious correlation as to why. Curious if there are any ideas as to why. Well, I think that's not really specifically an ALD thing. Many people with neurological symptoms or with spinal cord disease have fluctuate. Spasticity, for instance, can fluctuate. And some people say that they are worse in cold weather, or that they feel better in summer than in winter. So I don't think that's specifically something that is correlated with ALD. So I think that it is true that ALD is basically that the spinal cord disease is probably very slowly progressive, and the fluctuations in symptoms are aspecific. I don't have any better explanation than that. Now I'm trying to switch to the other parts of the question. Pain. Why do women with AMN seem to struggle with so much more back and leg pain than men? I do not know. The pain, the cause is probably the peripheral neuropathy and the spinal cord disease, but why it seems to be more than in men, I do not know. And the last part of the question, if there's a correlation between migraine, headaches and ALD, I would have to say no. Here we follow a lot of people with ALD, men and women, I think more than 120, and I do not get the impression that migraine is more prevalent than in people without ALD. You know, migraine is something that so many people have that I think it's a chance association. The next question is, our 30-year-old daughter just tested positive for the ABCD1 gene defect associated with ALD. She's a carrier with no symptoms at this time. Her mother has severe spasticity. Are there any recommended treatments or tests she should be aware of? Well, yeah, like we discussed, she is rather young at this point, so it is very typical that she has no problems at this time. And if there are no problems, yeah, then at this time there are no treatments that she should have. She should probably seek medical attention, yeah, for two reasons. If she is planning to conceive, it is probably wise to ask for genetic counseling. And two, yeah, if she has any complaints, you know, gait disorder, other problems that she thinks might be ALD related, then I would definitely recommend to seek out a neurologist. All right, question 2. When you read articles about women carriers, they usually say symptoms start around 40 years of age, but my numbness in my leg started around 28 years of age. Well, yes. You know, for the entire group, most women develop symptoms after 40 years of age. But yeah, as always, there are exceptions, and we also know women who became symptomatic much earlier. All right, question 3. Does the level of very long-chain fatty acids affect symptoms exhibited? Should we be tracking our very long-chain fatty acids and actively work to reduce? We don't think so. In our paper, we also looked at to see if we could correlate biochemical abnormalities with symptoms, and we could not. So we don't think that the level of very long-chain fatty acids, at least in plasma, is correlated with symptoms, and I don't think at this time that it is useful to follow that. Question 4. Is it possible that a woman with adrenal insufficiency has acute inactivation too? Well, what we are trying to do now is yeah, it's possible. We tried to see if we could find that skewed inactivation would explain why some women were symptomatic and others weren't. We could not find that association at this time, so we don't know. Question 5. Do women who don't exhibit an increase in very long-chain fatty acid levels manifest symptoms? Are they as severe? Yes. In our paper, we could find no difference between women with normal levels of very long-chain fatty acids and those with increased very long-chain fatty acids in plasma. So we don't think that at this time that is a predictor for symptomatic status. Question 6. I'm from Australia and I'm a carrier of ALD. I am now 43 and exhibiting some symptoms. I get a feeling of very cold burning feet, but my feet are not cold to touch. Is this a symptom of ALD AMN? Probably yes. That is probably a symptom from peripheral neuropathy. And peripheral neuropathy can have many causes, the most common being, for instance, diabetes. But if you have ALD, then I would say that that is probably the cause of your peripheral neuropathy. And it's probably a good idea to seek out a neurologist to see if you can get symptomatic treatment. Question 7. Do the women in your study all have the gene, whether symptomatic or not? Are they all found in families with affected members? That is that how you found the participants? All right. Well, yes. See, everybody with ALD, man or woman, has a mutation in the ABCD1 gene. And that was a criterion for inclusion in our study. You had to have ALD. So all the women in the study had a mutation. And are they all found in families with affected members? Yes, we all found them through either our clinic or through patient organizations. And there were very few who were most of them were found through male relatives. Yes, so they were all from larger families. Question 8. Did you find a relationship between blood very long chain fatty acid levels and severity of symptoms? No, we did not. Okay, question 9. Many symptomatic and asymptomatic carriers complain that they exhaust easily. Is there any subclinical endocrine dysfunction in the ALD area, such as subclinical adrenal insufficiency? Well, you know, that symptom, to be tired or to tire easily, again, that's a very aspecific symptom that many people with neurologic disease complain about. And I think it could also be explained, for instance, people with spinal cord disease, everything you do during the day takes more effort. You have to, when you walk, you have to be extra careful. Everything you do is an effort. So that is probably that could be an explanation why many people with neurological disease, with spinal cord disease, are more easily tired. Could there be, you know, subclinical adrenal dysfunction? Yeah, maybe that is something that we're going to look at now. Maybe that is something that we have missed in the past. So yes, we're going to look at that in the near future. Question 2 is, what do you think that symptomatic? Let me see. I don't completely understand the question, but is there? Yeah, I think it should be. Do you think that symptomatic carriers are similar to men with ALD? Well, basically, yes. I think the spinal cord disease in women is very, very similar to that in men. Just the age of onset and the progression is different, but it seems very similar to that in men. And the next part of the question is there any triggering factor, spinal surgery, etc.? Not that we could identify. We could not find any triggering factors. And then the third question is, do you think that girls or women with ALD should use Lorenzo's oil? No, I think they should not. Because Lorenzo's oil, there's much being said about Lorenzo's oil, but I think the bottom line is that there is no solid evidence that it has any influence on the progression of the spinal cord disease, not in men and therefore also not in women. So in our population, we do not recommend the use of Lorenzo's oil. Question 10. My understanding is that women with ALD that have the that have skewed X-inactivation do not develop ALD symptoms. Well, that is something we studied X-inactivation patterns with the limitations that I mentioned, and we could not correlate X-inactivation pattern in skin fibroblasts with being symptomatic or not. So I can't. At this time, we have not been able to prove that that is the case. Question 11. I am one of the few moms fortunate enough to find out about my son's diagnosis of ALD at birth, thanks to New York State's new newborn screen program. He's 5 months old now and scheduled for his first MRI next month. Thank you for having this forum for women. I'm curious to know My son's doctors confirmed I gave this mutation to him through genetic testing, but they never checked my C26 levels. Is this something that I should have checked? Are you more likely to have symptoms as a female if that level is higher than others? That's a good question. I would say the short answer would be no. If you have a clear mutation, then you have ALD, and in our study we could not correlate the plasma C26 levels with disease severity. So it would probably, if it would, with our current knowledge, it would not be a predictive factor. So I don't think it would help you to have it checked. Next question. My sister, who is 56 and is having difficulty swallowing, this came on very suddenly. Is this common? No, this is not common. And I would definitely recommend to see a doctor about that, because swallowing difficulties is something that is well, not a symptom of ALD in women, I would say. So I would definitely seek medical attention for that. Okay, the next question is, do you know that with physical therapy spasticity can be improved? Well, physical therapy is very important for people with disabilities and spasticity. So will it actively stop disease progression? No, but it can definitely reduce symptoms and keep you more mobile. So if you have complaints of spasticity, definitely start physical therapy. Right, the next question is there any special effort being made to find and test ALD relatives who show no signs? In extenso, those who have ALD but do not show signs. Okay, I think that the question is, if you identify somebody with ALD, then do you do extended family screening to find other people who have ALD but who might not manifest symptoms yet? Well, that is different country by country. What is common here, if we diagnose somebody with ALD, and if he's the first in the family, we refer them to the geneticist, and then they are offered extended family screening. So brothers, sisters, nephews, etc. are all offered the opportunity to come into the clinic and be tested. But of course we can't force anybody. What we do is we give the new patient information materials, and they can pass that on to their relatives and see if they are interested in being tested. So yes, it is something we try to promote, but whether people actually do it or not is something that is their personal choice. Question 16. What are the typical gait disturbances you've seen with carriers? Right. Well, the typical gait disturbance is what we would call a spastic gait, so caused by stiff legs. It's difficult to describe, but usually you see that that people walk with kind of extended legs, and that they kind of swing their leg around, something we call circumduction, but once again it's difficult to put into words. And some of them that have impaired dorsal column function also have a kind of a broad-based gait, very unstable. So that for neurologists, very recognizable. Question 17. Did you have women with normal or close to normal very long chain fatty acids who were symptomatic? Yes. Yes, we do. Yeah. Question 18. Is numbness in the hands resembling carpal tunnel syndrome a related symptom? I see mainly discussion of numbness in the legs here, so I can't help but wonder, since I have it in the hands instead of the legs. Yeah, that's a good question. Numbness in the hands is very unusual because the peripheral neuropathy in ALD usually, in my experience, especially affects the legs. And numbness in the hands is very unusual. So once again, if you have numbness in the hands, I would not immediately attribute that to ALD. I would really visit a neurologist and ask them to check for other causes, for instance, carpal tunnel syndrome. Let me see, question 19. If low, very long chain fatty acids do not affect symptoms, why does Lorenzo's oil work? Well, the question is if Lorenzo oil works. You know, Lorenzo's oil, if you look in the plasma, you see people who use a diet with Lorenzo's oil, they can reduce very long chain fatty acids, at least C26 in plasma. But whether that really affects symptoms or progression of symptoms is kind of dubious. There have been open label trials in men with spinal cord disease on Lorenzo's oil, and it has been shown that even if they use Lorenzo's oil, the symptoms of spinal cord disease progresses. So if Lorenzo's oil works is highly doubtful. Question 20. Has it been shown that CBD oil with THC has any effect on pain? I don't know. CBD oil is something that is hot right now. I mean, it's it's being considered for treatment, chronic pain, epilepsy, etc. Personally, I don't know of any studies that show that it is effective for neuropathic pain, but I haven't checked recently, so I'm not sure. Question 21. My family has a long and wide history of AMN ALD, but we are lucky that there has been no cerebral involvement. Does this mean that likely no one in our family in the future would have cerebral involvement? Yeah, interesting question. There have been studies in the past that show that that there is no what we call genotype-phenotype correlation. So we always say that we can't predict what kind of symptoms an individual will have. At the current point, we say there is no mutation that gives only AMN. So I would recommend that even in your family, that all men in your family still have regular checkups and MRIs, because with our current knowledge, we would say that even in your family, people would be at risk for cerebral ALD. So I would definitely consider continue normal follow-up. Question 22. I have severe scoliosis. I was braced for years and eventually needed spinal fusion surgery at the age of 20. Could there be a correlation between this and the carriership? I would say no. I think that is unrelated. Unless you had very, very severe symptoms of spinal cord disease even when you're very young, but otherwise I would say that that is unrelated. Question 23. While walking once, my legs buckle and give out. Is this a sign of ALD? Yeah, difficult to say over the chat box. Could be. But then if you want to be sure, see a neurologist and he can see if there are signs of spinal cord disease, and if there are kind of signs of spinal cord disease, the buckling of your legs could be related to ALD, yes. Question 24, is dizziness a symptom? Well, dizziness, every neurologist's nightmare because it's so aspecific. To answer briefly, I would say no, because dizziness is a symptom of your central nervous system or inner ear, and those are generally not affected in women with ALD. So I would say no. Question 25. Have you found any preventative measures that women can take to prevent symptoms from developing further? No, unfortunately, no. Like the spinal cord disease in men, at this time we have no proven treatment that can stabilize or prevent progression of the disease. Question 26. Have you ever seen a link with Crohn's disease? No. No. Again, like with migraines, I would guess that that's an association by chance. Question 27, just to clarify on the adrenal impairment, is there any evidence of a link with Addison's? There have been older studies from the Kennedy Krieger Institute that less than 1% of women with ALD have impaired adrenal function. So that is the data we have at this time. But it is something I think that is worth to examine again with maybe a larger group to see if that holds true. So at this time there is no clear evidence that women with ALD get adrenal impairment, but it might be something that we underestimate at this time. Question 28, could the increase in symptoms in patients over 60 be correlated with an increase in age? Well, yes. See, like in men with ALD, all men and boys are born without the spinal cord disease. So the spinal cord disease is kind of a neurodegenerative symptoms that develops over time. So it is probably because axons maybe probably due to the biochemical defect, you get slowly progressive damage, and that progressive damage, the damage to the nerve system, takes time to develop, and apparently it takes more, not just a few years, but generally so it takes more than 40 years to develop it. Actually, age is the only determinant of symptomatic status that we could find. Question 29. My wife is a carrier and we have two sons, 26 and 36. They have showed no symptoms to date. Should they be tested, and what are the odds that they are affected without showing any symptoms as of now? Let me see your wife's. Well, if your wife has ALD, your sons have a 50% chance of having ALD, and it is quite possible to be 26 or even 36 without symptoms. So I think it is really recommended that they be tested, because for them it could have clear therapeutic consequences. They should be, if they have the disease, they should receive follow-up, and they should be evaluated for instance, adrenal dysfunction. So I would definitely recommend they be tested. To be 36 without symptoms or without clear symptoms is definitely possible. Question 30. To your knowledge, are there any current research projects in progress in women with ALD, or are they planned in the short term? Well, yes, we have 2 research programs for women with ALD, but they are not aimed at therapy. What we are studying women now to determine the rate of progression, and we are also doing a study in which we see if measurements of the optic nerve are correlated with disease status. But if you mean therapeutic trials, I don't know of any that are currently ongoing in women. Question 31. Does the medication Vampira offer any benefit to women with ALD who suffer from gait dysfunction? Yes, possibly. Like with the men, people with severe spinal cord disease might have some temporary benefit from Vampira. Yes, I don't think there's a difference between men and women in this respect. The next question is, what are typical gait disturbances you've seen with carriers? I think we had a similar question earlier. Usually the gait disturbance is what we call a spastic gait. So because of the stiff spastic legs. Yeah, it's difficult to put into words. Yeah, that is something that would be better to illustrate with a video, but I don't think we can do that at this time. Question 33. What is the likelihood of women being tested in Australia? I don't know. I've never been to Australia. No, I don't know. But generally I would say that it is now pretty common knowledge that spinal cord disease can be caused by ALD in men or women. So most workup protocols for myelopathy that neurologists use would also involve ABCD1 testing. And since Australia is a developed country, I would say that that would probably be implemented. Question 34. Are there any studies for gene therapy for non-cerebral ALD? Not, as to my knowledge, not really in people yet. But there are people working on gene therapy for non-cerebral ALD. Yes, but I don't think they have progressed to the stage for clinical trials in people. That is for the future. Question 35. Right. So actually, okay, this is a follow-up question. I was trying to ask if it made sense to actively seek those women who have ALD but do not manifest symptoms on the theory that there may be something about them that we can use to or treat or cure who do manifest symptoms. Ah, right. I see what you mean. Now, at this time, I don't. Yeah. Difficult question. Maybe you mean maybe you could see try to find differences between the women who are asymptomatic and those who are symptomatic, because finding because then you might be able to identify factors which protect against developing symptoms. Yes, that's an interesting idea. Absolutely. That is something that we have tried to do. We have tried to see in what, if and how women without symptoms differ from those with symptoms. But at this time we haven't been able to find any factors. No. So yeah, that's an interesting thing. The difficulty, of course, is that when do you decide that somebody doesn't have symptoms? For instance, if you look at women who are 25 years old, and most of them will be completely healthy, but many of them will go on to develop symptoms eventually. So if you would really want to find groups to study, you would, for instance, have to look at women over 60, because those over 60 who have no symptoms are unusual. So to compare those with women over 60 with symptoms, that might be interesting, theoretically. It's a good idea. Is glaucoma linked to ALD? Ah, finally a question that has a short answer. No. All right. So that was all the questions. Thank you very much. Then I'm switching back to the presentation. One moment. I'm obligated to go back to the disclaimer. So I would like to repeat that the information and services provided by ALD Connect are for informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnosis, or treatment. If you or a family member are ill or suspect that you or a family member are ill, seek professional medical attention immediately. ALD Connect does not recommend or endorse any specific physicians, treatments, procedures, or products, even though they may be mentioned on this site. Please note that your participation in this webinar is completely voluntary and that this webinar will be recorded and may be available for rebroadcast at a later time. So, thank you very much for your attention, and would be wonderful if you would answer a few short survey questions, and well, I wish you all a very nice day.